I'd like now to introduce Dr. Robert Hendren, who will discuss, among other things, treatments available for adults with autism, including pharmacology, supplements, and who will briefly talk about the Meristem model relating to transitional age youth and vocational supports. Dr. Hendren, thank you.
Thank you. It's a pleasure to be here. I'm pleased that my talk is embedded within talks that present other aspects of working with people who are on the spectrum, because while I'll talk a lot about medications and biomedical interventions, I think it's important that those be considered within a context of community, with other kinds of supports, with other kinds of treatments that can create a full spectrum of what's going to be helpful. Sometimes I'm worried that psychiatry gets boiled down to just medications and just giving some kind of a pill to solve a problem. And while it can help in the overall context, it's the overall context that's most important and that we hope gets emphasized. So I thought Dr. Hossball and Ms. Kimball's talk help set a certain context that will continue on as I talk about medications. One of the challenges in the medical care for people that have autism, especially as they become adults, is where to find that medical care. When I was the executive director at the Mind Institute a few years ago, we were asked to help take over kids that were adults that were getting deinstitutionalized, as it was called, and put into community programs. And they wondered, could we put in video monitors in the homes that they were going to, and then have physicians and nurses be available if there were problems that came up as issues. I thought that was a great idea, and I went to the people that I was working with, the other physicians that were pediatricians and pediatric neurologists and others, and brought it up with them, and they said, you know, it is a nice idea, but we don't feel qualified to take care of some of the illnesses that develop as one becomes an adult, like diabetes or chronic obstructive pulmonary disease or cancer or a variety of others that happen as they're older. So then I went to the internists and I said, could we put a program together where we could help with this? And they said, you know, we're not trained to work with people who have developmental disabilities. We don't know about that population in the way that we feel like we should, and that there are certain changes and ways that we need to do things, working with families, gathering a history in a certain way that we would need to have additional training to be able to do. So in the end, we didn't do it. But it's remained as something that I've continued to be interested in saying, how could we do a better job of providing primary care for adults on the spectrum? We submitted a grant at one point to provide teleconferencing capabilities to primary care offices. And while it seemed like a great idea, the funding agency didn't fund it, and we'll try again, and hopefully we'll have more opportunity in the future. But Dr. Hossball was part of that grant with us as we went on to do it. As it mentions on the second bullet in this slide, there are increased rates of chronic medical illnesses. People on the spectrum are at greater likelihood of developing seizure disorder as they go into adulthood, to where up to 30% of people who have autism also have seizure disorder that didn't develop as an infant or a young child, as often occurs, but happened more as they got into adulthood, suggesting there's a second wave of changes and a second need for intervention. GI disorders can continue into adulthood, feeding and nutritional problems, metabolic syndrome, anxiety, depression, sleep disturbances. And the relationship then between being able to relate to the environment and get a full range of services is often one of the things that's the best measure of thriving and doing well for people that as they age into transition age youth and move on. The challenges, as I'd mentioned, are the shortage of people that are well trained to do this, the financial disincentives. There is at least a perception that it may take more time to see somebody on the spectrum, in part because they may come with other caretakers and family members, and it takes a while to listen to everybody and get multiple perspectives, and communication may be different. There may be barriers in someone on the spectrum being able to fully describe their symptoms. Certainly not all people, but some being able to put those into words, especially if there's not a lot of language. And there is generally a lack of formal education or training for people that are providing the care. I hope we can remedy that, and events like this are one of the important ways. If we could do something like this for primary care physicians, for people that are increasingly seeing people in their practice. I gave a talk yesterday in Las Vegas for a convention for mental health providers, mostly psychiatrists. There were probably 400 people in the audience. I asked, how many of you are seeing more people on the autism spectrum in your practice right now? And I'd say 80% of the people in the auditorium raised their hands. And each year when I give a talk, I ask that question, and I find each year more and more people are raising their hands. But then when I said, how many of you feel like your training or your background has prepared you to take people on the spectrum into their practice, most of them said no. So there's a huge need for us to meet this growing number of people entering our practices and thinking about their diagnosis, thinking about how we can make interventions as we move ahead, and thinking about treating comorbidity. So I'd mentioned some of the autism comorbidities. GI abnormalities occur in 30 to 70%. That's a broad range, I know. 70% is in a GI practice, 30% is in a family medicine practice. Seizure disorder, as I'd mentioned, was 30%. In DSM-4, we said that up to 70% of people on the spectrum had mental retardation, but that number has changed a lot now as we've gotten to a broader spectrum and identified people that are very bright and have autism, but they still have certain areas where they could use additional supports and benefits. There's been an increasing interest in mitochondrial disorders. Mitochondria are the little energy bunnies that drive your cells. And it's fairly rare if it's a full disorder, but it's been found in recent studies that 20 to 30% of people on the spectrum have mitochondrial dysfunction. And there are higher than expected rates of things like eczema, allergies, asthma, ear and respiratory tract infections, and headaches. There are also the psychiatric disorders that have been mentioned, or mental health disorders that we see. ADHD occurs comorbidly with autism in anywhere from about 20 to as high in some studies as 66% of people. That doesn't mean all of them need to take stimulant medication, but it does mean that there are certain ways that we can think about accommodating short attention spans, distractibility, impulsivity that can be helpful in treating those symptoms. OCD, obsessive compulsive disorder, can be part of autism and put into that diagnostic umbrella, but at times it becomes so marked that it's having major effects on people's lives, and we need to think about how can we make that a target of our intervention. And at times, psychotherapy techniques, especially CBT and others, can be very helpful. But finding CBT therapists that are comfortable working with people on the spectrum is often a challenge. And we have 2 or 3 at our STAR Center now, but there aren't many. There's a growing number, I think, but it's as it becomes more and more important to be able to do that. Over-anxious disorder is something that continues well into adulthood and becomes a problem. And was mentioned earlier, bipolar and psychotic disorder are increasingly recognized as being part of an autism spectrum. There was a study done of over 10,000 people, 10,000 adults in Sweden that indicated that there was a percentage point of about 2% of people with bipolar and up to 3 to 4% of people with schizophrenia. And it may have been those were people that were not properly diagnosed before, but certainly that continues and may be even more under-recognized. And aggression, while it often tends to level off in adolescence, for some people, particularly some that might have some intellectual disability issues, can have more trouble with aggression, so that we continue to need to use some of the powerful medications to help people from hurting themselves or hurting others. So as we think about interventions, there was a way that I thought a few years ago about thinking about how we're intervening for this disorder that involves the whole brain or even the whole body. And if we'd say that the surface, what we see outside in symptoms, is like the surface of the earth, and we used to think that when we got past that, we could say it's genetics. We'll explain all of this by genetics, and genetics is the core of the earth. But I think what we've discovered is that there is a lot that happens between the core of the earth and the surface of the earth that in some ways is a ripe area for intervention that can help, either if we're talking about near the surface cognition or brain structure and function, but in the middle, if we're talking about physiologic processes, that we can help the body function better and help it be healthier. And so what I'm going to primarily talk about are these level 2 and 3 type interventions. I had told the story, and I'll take a second to digress. My wife is French, and our daughter lives in Paris, and she has a French boyfriend, which worries me a little bit that she might get married and stay living in France, and I'm going to have to work on my French in order for that to work well. But he lives in Alsace, and his parents invited us to come for a visit, and when we were there said, would you like to have some wine? Or go wine tasting, and I said that'd be fun. And as we went to the different wineries, they talked about their terroir, the way that the land was a mixture of lava and sand and clay, and that those grew different kinds of grapes. And they said that's important about how the grapes grow, but what's also important is the amount of rain and the amount of sunshine that the land gets. But they said that's not all. What's also important is the hearts and souls of the people that are tilling the ground, that's what makes a great terroir and makes a great wine. And I thought, well, that's the way we grow healthy people. It's we have different kinds of soils, and we try and enrich those, and we try and think about how much rain and sunshine can we put on it, and how can we put our love and kindness into the soil as we're doing that. So I thought about, in autism, trying to make sure that we go at all of those layers to make a difference in how people are doing. So if we're thinking about that, and we think about the surface layer, that might be behavioral interventions, family support, and structure. And when I first presented this model, I said to somebody that was doing behavioral treatments, you're working on the surface of the earth. And the person said, this is Sally Rogers, and she said, oh no, Bob. If I'm doing my job well and I get people at the right time, I'm re-sculpting their neurons. I'm having an impact all the way down deeper by the things that I'm doing on the surface. And Sally, as usual, was right. But if we're thinking about working down a little further, thinking about speech and language and OT and therapy and CBT and that cognitive brain structure level, and then as we get down a little deeper, thinking about what can we do with pharmacotherapy, and then even things that are nutritional supports that help the body be healthier, to help it function at a much better level. And then the most dramatic would be gene modification, which I don't think we'll quite come to, and would certainly be controversial if it were, but is something that is being done for certain disorders that we could approach with this model. So for stimulants, as I'd mentioned, there are a number of people that have ADHD in addition to autism spectrum. Years ago, people used to dose those people too quickly and too high, and they found that they came unglued. They didn't think well. It affected their thinking. And lots of parents that I see come in and say, oh yeah, he or she tried stimulant medications years ago, and he just became completely off the wall. It wasn't good. Studies, though, that have been done more recently, like the RUP study mentioned there, and others with atomoxetine, that have started with a low dose and worked up slowly, have found beneficial effects for at least some patients, although there's still people with neurodevelopmental disorders are particularly sensitive to developing side effects, and then one has to be cautious and familiar with how to do that well. SSRIs, we thought, worked well for OCD-type behaviors. Those are selective serotonin reuptake inhibitors and work on serotonin, which is a neurotransmitter that's been consistently shown to be dysregulated in autism. But there was a double-blind, placebo-controlled trial done a few years ago on young people with autism who had OCD, and it was a negative study. So people wondered whether there was too high a placebo response, maybe it wasn't the right dose of medication, or maybe it didn't work as well. But there is one positive study done for OCD and autism using fluoxetine, which is Prozac, that showed that the active treatment group separated from the placebo group. And that study has withstood the test of time, saying that it appears that at least in adults, SSRIs seem to be helpful for OCD-type symptoms. Alpha-Adrenergic Agonists are blood pressure medications. They're called clonidine or guanfacine. They tend to help dampen down some overactivity. It can help sometimes with sensory sensitivities. It can help some even with ADHD-type symptoms, and it can help with anxiety. They have blood pressure side effects, so you can't titrate up fast or go off quickly, but they have a fairly good side effect profile and are helpful to some. And I know I'm going through things that could take hours of time spent talking, but we're hopeful that we'll have discussion time, and if people want to know more, we can talk about them. And then finally, antipsychotic medications, which I think have the best and the worst of reputations in psychiatry. Sometimes people come to see me with a child that's been thrown out of all of his classes. They're worried about what he might be doing to his siblings. Life's been really disrupted at home. He's miserable. He's not able to do very much. And an antipsychotic medication can make a big difference for the right person and can help them function better. But they carry the risk of weight gain. They carry the risk of lipid disorders, increased cholesterol, triglycerides, increased glucose. And if they were to continue for a long while, that can also run the increased risk of developing type 2 diabetes. And sometimes people feel like maybe it changes their personality. So we try and make sure that we cautiously introduce the medication, use the most effective dose, try and come down on the dose occasionally if we can, and see if we can't even get caretakers that are sensitive enough to go up and down on the dose when they're recognizing that this is going to be a difficult time, or come down on the dose when it looks like things are going pretty well. But much like people with diabetes adjust their dose of diabetes depending on what they kind of sense is where their blood sugar is, I think people can use these medications to help titrate the dose to fit with the particular circumstance. So stimulants work for some, but start low, go slow. Antidepressants, maybe SSRIs, especially for adults. Alpha-adrenergic agonists, worth a try. Anticonvulsants, especially when there's neurologic abnormalities, may be helpful. And antipsychotics, at least risperidone and aripiprazole, Abilify and Risperdal, have an indication for treating irritability in autism. And there are several others that have perhaps better side effect profiles that are perhaps being more useful in the long term. I'm going to in the last part of my talk, just kind of go through a few biomedical treatments that I think are worth considering. There have been good studies of melatonin for sleep, generally somewhere between 3 milligrams and as high as 9 milligrams. If one's taking melatonin for the sedation part of falling asleep, that can be given 30 to 60 minutes before going to bed. But if you're trying to reset your body's clock, then it's better to give that melatonin at somewhere around 7 or 8 at night. There are a number of different preparations of melatonin that you can find at the health food store or online with a variety of places. The studies that we did were done with some from twin labs, but they're not necessarily better than any others. But melatonin can help not only with sleep, but there's at least some preliminary evidence that perhaps it helps with immune function. Vitamin D, just 2 weeks ago, there was a study released showing that vitamin D seemed to be a benefit to people in a randomized controlled trial, our gold standard, a benefit to people that were both youngsters and adults on the spectrum. And they were giving about 5,000 international units for full adults. But we sometimes for smaller people give 2,000 international units of vitamin D and have found that it's helpful, and we've been doing a trial at UCSF as well. NAC is N-acetylcysteine. It's an amino acid. The first major study that was done and published was done by Antonio Hardin at Stanford, showing that it made a difference for irritability, but there have since been studies showing that it helps with self-abusive behavior, particularly like bad fingernail biting or picking at scabs or picking at cuts that just don't get healed. And NAC, up to 2,400 milligrams a day, generally given 1,200, titrating up slowly, was of clear benefit and is increasingly thought of as something you could get at the health food store. Seems to be just a nutritional supplement and doesn't have side effects. Omega-3s have been shown to be a benefit for autism, generally around 1 gram a day. We've done 2 studies at this point showing a strong trend towards improvement in taking omega-3s, and I encourage all of my patients to think about taking omega-3s, vitamin D, melatonin if they need it for sleep. And I can't recall vitamins and minerals. Some people say it makes expensive urine, but there are some good vitamin studies that suggest that it's a benefit. This one, done by Jim Adams, was done with an online product called Empower Plus, but there are a number of other good ones from Kirkman Labs and a variety of places that are specially formulated for people on the spectrum and can be a benefit. Diet, the studies have been real up and down about whether it makes a difference. There was an early study of the casein gluten-free diet done in, I think, Denmark, saying that it seemed to make a difference. A lot of other studies have failed to replicate that. I would tell you, though, for patients that I see who had a GI problem of some kind or another, that often trying the elimination of casein and gluten or one or the other at a time has resulted at times in people noting real improvement. And I have adult patients who've told me that it made a big difference for them when they gave up gluten. But I find that for adult patients that aren't on the spectrum as well. It seems as people get older, they get a little less tolerant of both casein and gluten, and perhaps trying an elimination diet might be of some help. There's been a lot of interest in oxytocin and the role that it might have. The problem with oxytocin is that it lasts not very long. You have to get it by nasal cannula. You can't wear it all the time and use all the time. So a company, Roche, came and developed vasopressin, which is very similar. They're both neurohormones. They're both naturally occurring. But in the study of vasopressin, it appeared that it was making a difference for people, and this was a study only of adults on the spectrum. They haven't published those results yet, and vasopressin isn't released for general use, but the company has now gone to the FDA, and I assume the FDA must be interested because now they've started a study for kids that are on the spectrum, although they haven't published the results and haven't put vasopressin out yet as a treatment for adults on the spectrum. But it gives hope in a certain way that maybe we're thinking of new strategies that might make a difference without harmful side effects that could make a difference in the outcome for people on the spectrum. Medical marijuana. I have to tell you, when that was a patient first asked me about that 5 years ago, a parent saying, what do you think about medical marijuana? When I I'd like to keep an open mind. And so I said, we've tried almost everything, and I'm willing to give this a try. So I wrote for someone to have it, and it seemed to make a modest amount of benefit, not a lot. I wasn't sure who in the family was taking it, and which was a little bit of some concern in using it. But since then, they've become a lot more refined. For a while, they went a lot to CBD, which is cannabidiol, which is the non-psychoactive component of marijuana. Now they're they said that didn't seem to work too well either, but now they're adding THC into the CBD in different ratios, and I have a number of patients who are taking it largely because of their aggression, and it seems to help them be more calmed without seeming like they're stoned or out of it, and make some modest difference. And a very large drug company has developed a product with cannabidiol that they'll soon be testing on the market as a prescribed medication that may be of help. I'd mentioned some of the other rarer things to try, like vitamins. There was a real interest in GABA-A. GABA is in benzodiazepines. Problem is that they tend to wear off in their effectiveness, but there was an interest in arbaclofen, especially for treating Fragile X. That trial turned out negative, and so they stopped the arbaclofen trial. But there are still other trials going on looking at GABA as a potential treatment. So I think that it's important for us to consider thinking about all levels using my terroir model and saying, let's make sure we're thinking about treating everything we can treat as well as we can possibly treat it. So thinking about the medical aspects, some people think it's worth getting genetic testing. Many people recommend it as at least a routine thing, although it rarely changes treatment. The input of neurology, particularly if they're well skilled in autism, but especially if there's a seizure disorder. GI can be helpful, although I find when I refer people with GI problems to see the GI specialist, they generally recommend probiotics and pancreatic digestive enzymes as the first step. So that's usually what I do first, rather than send them to the GI specialist, and then if that doesn't work, I move on. And thinking about other medical symptoms, especially for people that might have trouble describing the medical symptoms. So someone that might have a lot of gastrointestinal reflux may not be able to say what that is, but we see them humping over or bending over a chair or pushing at that area of their chest that's hurting them because of the reflux. And there can be other symptoms that show up like that. Being sure that we've made full use of speech and OT, thinking about behavioral interventions, treating associated symptoms, sometimes with pharmacology. And then, as I'd mentioned, I think about using melatonin, omega-3, vitamin D3, probiotics, and pancreatic digestive enzymes. In terms of thinking about, I have just two final slides on thinking about vocational type interventions. I had been very impressed with Autistry Studios, which is in San Rafael. They have thoughtful programs, especially for transitional age young people. And I felt that they show a good result. Actually, what this first slide, though, is saying that actually about 50% of people on the spectrum have ever worked for pay. And when they have, their hourly wage is about $8.10 an hour, which is far less than even other people with developmental disorders make. So it becomes a big problem. But I'd mentioned Autistry Studios. When I was in Sacramento, I worked a lot with Pride. I think they do a marvelous job, and still see some people that are being seen in Pride. Recently, though, we were asked to do an outcome study for Meristem, which is in Fair Oaks, which is just outside Sacramento. They created a partnership with Rudolph Eckstein University, which is a Waldorf's training college. But on this 14 acres of land, they have a working farm, they have farm animals, they have a 2 or 3 year curriculum that has people learning different steps in a way that helps engage their interest fully, like they make compost They use the compost for this fully organic garden. They sell the products from the garden to local restaurants that want fully organic produce. Or they have sheep, and they shear the sheep. They spin the wool into yarn that they make into blankets and into belts. And there are 4 or 5 other examples of things that people do, including a lot of movement and centering in the body, based on a model that was developed in the UK that was called Ruskin Mills. And we've been impressed with their model, and right now we're doing a year-long outcome study to see whether it really seems to make a difference vocationally for young people. So I think there is increasing hope, but as I think both of our previous speakers mentioned, it's just been such a sad occasion to see people on the spectrum grow into adulthood and not find the kinds of services they need. And I applaud this group in having this meeting and hopefully many more to help address those things. Thank you.